Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. What's going on in this image here? A hematoma, correct? And do you know which type? Yes, an epidural hematoma. And you know that without reading the caption because it has the classic lenticular shape, correct? Right. See, I know you're smart. We're going to be talking about traumatic brain injuries pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the website where updates and great material all exist for you to do your best on Step 1 and with Medical School Pathology. Here we have an epidural hematoma again, right? See that lenticular shape? Now, an epidural hematoma develops when blood accumulates between the skull and dura mater. Epidural hematomas are usually the result of skull fracture and rupture of a major vessel of the brain. Neurologic symptoms like lucid intervals may come initially. Radiology of epidural hematomas classically, as you're aware of, show a lens-shaped lesion representing the dura being separated from the skull by the hemorrhage. Now, some complications of epidural hematomas include herniation, seizure, and death. For this reason, all my future surgeons, listen closely. For small hematomas, you may need to monitor the hematoma closely because some of them are likely to heal on their own, but the patient might need to stay in the ICU, okay? There'll be all sorts of sensors to gauge the pressure and whatnot. You might be on call for this in the future. And regarding large or quickly developing hematomas, for that, surgical intervention might be needed ASAP. A burr hole might be created to drain the blood from the skull with a tube, or even a craniotomy. So this might be in your near future, all you future surgeons, and specifically neurosurgeons. Kudos to you. And why do epidural hematomas happen, right? Well, because the interior of the skull has all these ridges on it, some of them more sharp than others. And when there's a trauma, you can imagine that there's this tearing that occurs, and then blood accumulates. And here we have a cartoon showing a depiction of an epidural hematoma. And sometimes it's not as easy to see, to visualize the epidural hematoma on imaging. But if you look closely, you can see that this non-traumatic epidural hematoma that is present in this young woman is represented by the gray area in the top right, which is an organizing hematoma causing the midline shift and compression of the ventricle. And when I say top right, I mean patient's top right. Radiologists and future radiologists already knew that though. And now you do as well. Now, we know that an accumulation of blood on the surface of the brain is known as a subdural hematoma. Can you recognize the difference, right? We're talking about subdural hematomas. Now, you might be saying, that looks lenticular to me. And your assessment would be reasonable. But future radiologists know out there in the crowd that it actually has a more crescent shape, right? You see that? If you look closely, you could see it. Maybe it's more obvious with this one, right? Now, Subdural hematomas develop after trauma because the bridging veins between the dura and arachnoid rupture. So we know that the radiology of subdural hematomas reveal a lesion with a crescent shape. But what does the histology look like? Well, here, future pathologists, is a micrograph of a chronic subdural hematoma, demonstrated by thin strands of collagen and neovascularization, right? The development of new blood vessels. Keep in mind that subdural hematomas may present with neurologic symptoms that progress with the severity of the hematoma. Also, age-related cerebral atrophy, which stretches the veins, contributes to an increased risk and an increased rate of subdural hematomas in the elderly. Herniation is a potentially lethal complication of a subdural hematoma. Here we can see a subdural hematoma, specifically chronic subdural hematoma after treatment with the burr holes present, right? And note regarding herniation, which we're going to talk about more now, specifically herniation is the displacement of brain tissue as a result of a force or higher intracranial pressure, okay? That's a herniation. And you can see that in this MRI. The most frequent type of intracranial herniation is a subfalcine herniation, which you will be likely asked about. In a subfalcine herniation, the brain tissue protrudes through the falx cerebri. And an uncal herniation, which you will definitely be asked about, is another type of herniation in which the temporal lobe uncus is displaced under the tentorium cerebelli. And you're specifically going to be asked about an uncal herniation because it's easy to tie in with neuroanatomy because there's this compression of cranial nerve 3 that happens, and the ocular motor nerve causes ipsilateral eye to move down and out and the pupil to dilate when an uncal herniation is present, right? And speaking of cranial nerves, what are the cranial nerves, right? You know the 12 cranial nerves. Tell me them real quickly. To reiterate, you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 as olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, right? Vestibulocochlear, glossopharyngeal, vagus, accessory, and the hypoglossal. Now, other potential complications of herniation include cardiopulmonary arrest, and that occurs when the brainstem is compressed. Could also have infarction of the occipital lobe or the opposite homonymous hemopia, which are caused by compression of the posterior cerebral artery. And note, infarction occurs when the anterior cerebral artery is compressed. Herniation can also result in seizures and death. And with that, you've concluded a very important, highly tested topic, so kudos to you. Great job. I hope the future radiologists appreciated this. I hope the future neurosurgeons appreciated this. Neurology, I'm looking at you. Everyone else, you will be tested, and I'll see you later. Great job.